Get started. Right, so I'd like to introduce Emma, who will tell you a little bit about herself shortly. This recording will be on the StrokeEd website for the foreseeable future, and it's available at the top of the website under the resources tab and lectures. This is the second recorded lecture that we've done about groups. So last year we had a recording about organising and running circuit classes by Zheng Chao. So if you want to access that on our website, you'll be able to hear a bit more about that. This will run for about an hour, possibly a little bit longer, depending on the amount of questions. And Emma has some references that she'll share with you at the end. So I'll hand over to Emma now.
Thank you, Annie. So I am an occupational therapist, and I'm an associate member of the StrokeEd collaboration. So you might have seen me if you've attended some of the other learning resources. And I'm also an occupational therapist at Alfred Health, which is one of the acute hospitals here in Melbourne. And I'm also an adjunct researcher with the Monash University and a lecturer with Swinburne University of Technology. So I am excited to be speaking with you this evening. The topic, as you already should know, is how we can use groups to increase the amount of practice in rehabilitation, which is an area that's quite passionate to mine. First of all, I would like to complete an acknowledgement of country. I respectfully acknowledge the Boonwurrung people of the Kulin Nation, who are the traditional owners of the land on which I am located in Melbourne South, and pay our respects to their elders past, present and emerging. I also acknowledge and respect the traditional owners of lands across Australia, their elders, ancestors, cultures and heritage, and recognise the continuing sovereignties of all Aboriginal and Torres Strait Islander nations. I also extend this acknowledgement to any traditional owners of lands on which you are meeting today. The learning objectives for tonight's session, there are three. We're going to be looking at how semi-supervised practice or groups can be used to increase the amount of practice provided in rehabilitation. We're going to learn how the intensity of practice in an upper limb group can be targeted through implementation meetings and professional development, and discuss strategies to adapt group sessions in response to organisational or even infection control barriers. And I'd encourage you to share your own learnings, as I'm sure everyone's had some different experiences over the past few years. So first of all, we're going to really look at how and why semi-supervised practice can and should be used to increase the amount of practice provided in rehabilitation. My systematic review was published in 2016. I've included a little QR code up on the screen. This article is freely accessible online, and it was a systematic review that was completed to look at the effect of increasing the amount of usual rehabilitation and if it led to improved activities after stroke. So the systematic review looked at randomised control trials and quasi-randomised control trials that delivered usual rehabilitation and then extra practice of the same content on top of that. So if a trial included usual practice of arm and reaching practice, any additional reaching practice that would be considered extra, but not the other things that weren't targeted to arm reaching and grasp. So really looking at that extra dose of the same thing in terms of determining that amount of intensity on overall outcome. And this is a forest plot on the screen, and there are 3 diamonds, but if you look at the one at the very bottom, which is the overall effect of all of these reviews that were included in the systematic review, that has a standardized mean difference of 0.39, which does favour experimental. It does favour providing extra therapy. So looking at that dose response relationship between amount of practice and improved outcome. But there was actually a lot of variability in this initial finding, and we had to go back and really look at the trials to determine what was causing that effect. And it ultimately came down to the total amount of practice that was delivered across the trials that we included. So when we divided those trials up to those that delivered a small increase in practice, so less than 100% extra, so that amount on top of, and those trials that delivered a large increase, so that 100% or more, which is that large increase in practice, those studies below, we were able to really see the big difference when it came down to that dose. So small increase in practice, the triangle is right on that line of null effect. that a little bit extra didn't really seem to make a difference. But when there was a lot extra, more than 100%, the diamond is actually quite far off to the right, and there was a standardized mean difference of 0.59. So that really does show that the effect of an extra amount of rehabilitation, more practice, leads to better outcome at the level of activity. We did some other calculations, and we found that the minimum amount of extra practice that's needed to guarantee or indicate that more benefit would be seen is that 240% increase to be sure that there would be a change in activity in stroke survivors. So what that really means in practice is if a therapy service is actually providing in their usual practice when they're targeting arm and hand practice, if there's only 30 minutes of reach and grasp rehabilitation delivered per day, in order to ensure or guarantee that significant likelihood that someone's going to get even better than they would normally, that 240% increase is actually 72 minutes. So that means a total of 102 minutes of reach and grasp rehabilitation per day would be required. Now, this is just reach and grasp practice, so more of the same. We can't keep mixing multiple different things in because that doesn't lead to an intensity of practice change. But I think we just want to stop here and acknowledge that that's a lot of practice, right? 100 minutes a day is a lot, and by no means are we expecting for a therapist to be there for all of that practice. So how can we look at ways to deliver that practice? So we need to triple the amount of practice, and there's two obvious ways or channels that we can go about doing that. The first one is obviously to increase the amount of practice time, i.e. we schedule more therapy, whether that's more one-to-one therapy where there's one therapist, one patient, or we look at other alternatives to deliver practice, such as semi-supervised practice or groups where there's one therapist to two or more patients. Or there's even independent or self-practice where homework is set, the person's trained to complete that homework, they go away, they do that self-practice, and then they come back and that record is checked to determine that the practice was completed. So there's different ways that we can schedule practice time, and obviously group semi-supervised practice is one of those methods. Another method is actually to increase the practice intensity. So maybe someone's already scheduled for 60 minutes of therapy, but maybe they're not working at the highest intensity. Maybe there's opportunity for more practice to be completed in that time that's already scheduled. So we can look at increasing practice repetitions or the number of minutes or the amount of time spent in actual practice. We can do that by reducing rest breaks and setting clearer expectations regarding practice for the session. And the expectations aren't just for patients, that we set them up with the expectation that when you're in therapy, you're here to practice. But I think we also need to set expectations for ourselves as therapists, that we need to be prepared and ready to help this person practice straight away as soon as we get them set up into their session. We need to set practice targets in terms of the number of practice minutes or the number of repetitions or both, and provide really clear feedback and instruction in how goals should be achieved and repetitions should be practiced. And there are some great resources that you might already be aware of in terms of increasing practice intensity. And ideally, we could do both of these things and lead to a triple the amount of practice delivered in rehabilitation. Already, we're really identifying that there's a really large amount of practice that needs to be delivered in order to improve better outcomes for arm and hand activity. So what's the benefit of groups? I think that's fairly obvious, but let's just spell it out in case we're not really across it. But if we're trying to deliver 100 minutes of reach and grasp practice per day, that can be achieved by delivering 3 35-minute sessions of actual practice. However, what we know from audit and observational trials is that 35 minutes of practice is often delivered in a scheduled 60-minute session. So we often say that we see people for an hour, but traditionally there's only about 35 minutes of actual practice that's delivered. Go away and audit some of your own practice sessions. You might be really shocked by this. And if you are delivering more than 35 minutes, then you should be really proud of the efforts that you're making, because that's more than the standard. So if at the moment, if we want to deliver 100 minutes of actual practice, if we were doing one-to-one therapy, we would need to see someone for 3 hours, which is a lot of time. Now, I'm not expecting that you can do that realistically. So it's showing us quite clearly on the screen, this is not feasible unless you're in some amazing private practice where someone's got unlimited budget. but it's not feasible to do this. So we have to look at different methods of service delivery to deliver that amount of practice. Another option is here on the screen, using maybe one-on-one session, setting up a supervised group for semi-supervised practice, and setting homework for more independent practice. So that could take up to about 120 minutes of a therapist's time. But if someone else was maybe running the group, all you might need to do is do the one-to-one session. And already it's only you're taking 60 minutes of your time, which means you can divide your time more between the other patients that you have to see, but the person is still achieving that 100 minutes of actual reach and grasp practice. Now, if any of these sessions actually had a higher intensity of practice, at a minimum, you'd need 2 hours maybe to deliver the 100 minutes of practice. And maybe we could reduce one of the independent sessions or the one-on-one sessions to still deliver that practice. So already we're looking at the way that service models can be redesigned to ensure that we're delivering increased practice in rehabilitation. I actually found this myself when I was doing a feasibility trial. So this is a published article. I've got the QR code on the screen as well. This is a feasibility trial. So essentially I did my systematic review and then thought, that's a lot of practice. How are we actually going to do that? And one of the ways that we first tried was to look at offering an additional practice session. There's some literature and data to show that often in rehabilitation, patients feel that they're a little bit bored, or they've got free time, but they don't really know how to spend it. And they're often feeling like they can do more in the time that they have available, but they're not really sure how to go about doing that. So we really wanted to provide or offer an additional, an extra 60-minute practice session to people who are already participating in an inpatient upper limb rehabilitation program. So we tried to recruit, and in fact we did recruit 20 people to participate in this feasibility trial, and they were asked to complete 60 minutes of extra upper limb practice 6 days a week for 4 weeks. Now that's 60 minutes of actual practice. So they were already warned that they might be in the session for more than 60 minutes, but they would need to be there for the whole time until they had completed 60 minutes or until they gave another valid reason why. And this was on top of their usual rehabilitation. And we really wanted to see first if it was even possible to deliver that practice and for people to actually be able to do it in their rehabilitation program. And the great news is that, yeah, they were, but we actually found a number of challenges to delivering that practice across the feasibility study. So there were a total of 480 sessions that needed to be delivered. And you can see that there was quite a high attendance rate. There was 72% of those scheduled sessions attended. But you'll also notice that the majority were actually delivered in a class format. Now, that was not the intention initially, but it soon became apparent that was going to be the only way to feasibly deliver that practice. Often people weren't available during the normal working day. They were already engaged in therapy, or they were getting actually ready, like they were engaged in ADL tasks, like getting showered, getting dressed, eating, or they were actually visiting with their family, or they were attending other appointments or speaking to other rehabilitation staff. And what ended up having to happen is that the sessions ended up needing to be scheduled at about 4:30 in the afternoon, between 4:30 and 5:30, or 4 and 5:30, which was just before their dinner arrived at about 5:30 or 6 o'clock on the ward. And that meant that no other therapists were actually available or on the ward then, because everyone usually went home at about 4:30. So the participants were there. Sometimes they had some family, but the family wanted to come and actually be a support in the group. They created this group environment where people were peer leading each other, peer supports. There was a great culture, and actually the groups ended up being delivered on the ward. There was a space on the ward where people could easily be ported to, because it was just myself and the nurses. So we actually did it on the ward in a shared space on the ward, and we ended up delivering that practice in a group. So you can see here that the practice minutes, so on average each session, they practiced for 57 minutes and the target was 60 minutes, but the duration of each session was 73 minutes. So it took about an extra 15 minutes in order to get someone set up, get someone packed up. Maybe they did need a little bit of a break, or there was time between setting each of the equipment up for them to do their practice. But also, unsurprisingly, but might be shockingly to you, the usual care intervention, people were actually only scheduled for about 37 minutes a day. So this is data that shows that on average, people only scheduled, or they complete about 37 minutes of practice a day. But that was all usual care intervention. It wasn't just upper limb therapy. So this was quite a significant increase in the amount of practice that they were receiving usually. Overall, the trial obviously found that it was feasible for people to participate in that extra practice. So we definitely know that people can do more if they're asked to do more. And that's highlighted in the stroke guidelines under the amount of rehabilitation in chapter 5 under rehab. And there is consistent evidence from systematic reviews that the increased scheduled therapy time has an effect on improving walking ability, arm function and quality of life. And there's also a recommendation for circuit class therapy. And as Annie said, there's already a webinar available on StrokeEd around implementing circuit class. There's also a consensus-based recommendation that stroke survivors should be encouraged to continue with active task practice outside scheduled therapy, such as self-directed independent practice, and semi-supervised practice, such as groups, and supporting family, friends as appropriate. So we definitely know that this is something that we should be doing in terms of delivering practice and delivering rehabilitation. I'm just going to pause briefly. I haven't seen anything in the chats yet, Annie, so I might just keep going. We're going to move on to section 2.
Yeah, there's no questions at this point.
Thank you. So now we're going to learn how a professional development program combined with targeted implementation meetings could increase intensity of practice. So I think Annie had circulated this paper as part of the reading, and I know there's a link in the chat as well for this paper, but there's a QR code on the screen if you haven't yet had a chance to access it. But this was a trial that was done back in 2019 or published in 2019. Essentially, the context is that we had an inpatient rehabilitation program, and there was a group that ran 5 days a week. I think it was 10:30 to 11:30, and it was a mixed population. So anyone in an aged care rehabilitation bed or in the neurological, orthopedic, or mixed rehab could participate if they had upper limb goals. And what we noticed is that even though this session was scheduled for 60 minutes, the amount or the intensity of practice that was being undertaken in that class seemed to be quite low. And we did a measure of the intensity of practice, and I'll show the data at the end, but essentially we weren't really happy with how much practice was actually being delivered in the class. So what we did is we used this professional development program with implementation meetings, and I'll explain the development program in more detail. But we also did an audit to measure the intensity of practice after the intervention, and then we did it again 6 months later to see if the results had stayed the same or if they changed after the intervention stopped. So what happened in terms of that intervention is that StrokeEd actually came to our work site and was one of the locations for a theoretical and practical workshop, which is the evidence-based upper limb retraining program, which is now 3 days. So some of the staff attended that group, but not all of that staff. And the staff who were involved in delivering the upper limb rehabilitation group was actually quite varied across neurological OTs, orthopedic OTs, and spinal OTs. So it was very mixed. So in order to make sure that we were able to implement that learning into our clinical program, we also held implementation meetings with staff. We had 3 of these and they ran for an hour. And the purpose of those meetings was really to review best practice, identify any barriers that we could see locally that would stop us from being able to put that evidence into practice, and then actually develop a process for implementing the best practice guidelines into rehab. And we really tried to discuss the overall evidence in context of the upper limb classes and what it actually meant. We were very solution focused for resource allocations and really looked at developing clinical skill development, providing mentoring, and really tried to lead solutions to identify any barriers that we had found. So this was all very personalised and targeted. And I also want to say that no one actually turned around to say, well, we need more training and mentoring, or we need this. That no one ever really tells you exactly what they want. It's very rare. But what you often hear is, oh, we don't have time, I don't know how to do that, or we don't have the resources. So what we used to help us figure out exactly what was going on are the theoretical domains framework and the behaviour change wheel. Now, you may be familiar with some or both of these already. There are QR codes available on the screen to access some of these resources, but they're also very available online. Like if you just Googled some of these terms, you would find resources pop up quite quickly. The behaviour change wheel really comes down to this green circle, this capability, opportunity, motivation. And this talks about someone's physical, psychological, reflective, or their personal reasons for wanting to think about changing their behaviour. Or if we change opportunity, it actually has an effect on capability and motivation. If we change motivation, it also affects capability and opportunity, and so forth. Then there's suggested intervention functions, which are in red. Maybe education is best, or maybe training or enablement might be best for one of those criteria. And then the grey one around the ends are the policy categories and how they all overlap and interact. This is another way of describing the capability, opportunity, motivation component. So the inner wheel of the behaviour change wheel, and the TDF, the TDF domains, which was, as I mentioned before, the theoretical domains framework, so both of these can be used together, the TDF domains. So what we really found is when our staff were describing barriers, they really came down to knowledge and skills. Some of our staff didn't really know why the amount of practice was important, and know why delivering evidence-based stroke guideline interventions were really important to affect change. But they also didn't have confidence and skills around delivering some of those interventions. And that's why we really led to those mentoring opportunities. There was also some information around the environmental context and resources. There was reports that maybe they didn't have access to some key resources that they needed in order to be able to deliver some of those intervention models. They didn't have counters or clicker counters, or they wanted more resources in order to count the number of repetitions. They wanted to change the way that programs were set up, and their autonomy in being able to be the therapist in the room leading that program, that if they saw someone with an upland program that they thought they wasn't challenging them enough, that they had the autonomy and the authority to change that program and make it more advanced or progress it in a certain way to ensure that that level of challenge was always at the right target. And there were also some other factors in there around making sure that we were, about our beliefs and our consequences, and that we were really clear in terms of how we wanted to change the group and why it was important. And we made sure that we had operational and organisational responsibility too. So everyone knew that our manager wanted to know that if we were making change in this group as well. So I think motivation was definitely there. We made sure we addressed the capability, and we made sure we improved the opportunity. We even looked at the way staff changed and how we scheduled different people to run that group and how people were matched up. We looked at the way that we would rotate staff through, because some of our staff rotate every 6 months, and staffing definitely had a big impact overall, because people change over time, and it was how we could keep running those training sessions in the end that we also needed to really think about. So this is more from the theoretical domains framework. When I was talking about knowledge and skills were definitely some of the two areas that came up. What do they know what the guideline says? What do they think the guideline says? What do they think the evidence is? Do they know they should be doing, delivering high intensity evidence-based upland rehabilitation? So these are just some examples again from this Mishi article that you might find helpful in thinking about how you might address particular domains or barriers in delivering this change of behaviour. Remember when we're talking about staff behaviours. So once we targeted staff behaviour and staff knowledge, staff skill, the environment within that environmental context, we can now see the overall amount of practice that was delivered at month 0. So at baseline, even though the group was 60 minutes, on average, people only practiced for 17 minutes, which is quite shocking, really, isn't it? And on average, there were only 53 repetitions, which is not very many at all. Okay, so then we did the implementation meetings. People attended the StrokeEd course, and we made sure we translated that learning to our local context with support. After that, we then found that the practice time was 45 minutes and that there were 348 repetitions. So there was a significant jump in the amount of practice that was delivered. And I haven't got it on this slide, but the the duration of the group remained at 60 minutes. It's not like the group went for longer. We definitely increased the intensity. And at month 18, you can see between month 12 and month 18, the data didn't change significantly, and it showed that the change actually was sustained after that period. So I would probably say now, reflecting on how much staff's changed, I would probably recommend that it's that maybe after 6 months, we probably need to think about doing something else, but that didn't come through in the data. It definitely showed that once we addressed that cultural change, that we had strategies and things set up in terms of staff, and they knew what they had to do, that we made sure that was held accountable at an organisational level. It definitely seemed to carry on for that period of time. So I think it's each individual's setting needs to be addressed to see if they can have that change. Overall, they were very impressed and pleased with the amount of intensity of practice that we saw change just by targeting staff. Again, Annie, I don't see any comments.
Not yet, no.
Great, okay. So our final point is to discuss strategies to adopt group sessions in response to organisational or infection control barriers. Now, I appreciate that across all of the places where you're coming from today, you may have been exposed to different requirements. Our health service was actually one of the COVID hospitals, so we had priorities across our service that limited groups. In fact, we were not allowed to run groups from probably March 2020 until about October 2022. So we were not able to deliver groups in that time. And I think what I've really reflected on is, given the change in staffing that we've seen and that we normally see, we're now at a point where we have staff who are working with us that have probably never seen a group or never run a group, and probably never even been exposed to group dynamics, even on placement. So it's kind of like this whole new environment to running groups. And I think being able to take a step back and actually looking at how we just design groups, deliver groups, and actually monitor groups to make sure that they're working as efficiently and effectively as possible is really key. I also recognise that we are not able to run our groups like we did pre-COVID. So we're still having to adapt and monitor, which I also think is, exciting in a way, because it gives us that freedom to keep changing in response to evidence and different environmental factors that might make it easier to do. So when we are thinking about running groups, we really need to be clear about what it is that we're trying to change or what we're trying to target. So select the target behaviour or the target goal. And obviously for our service, we already had a group running at the time, and we were really wanting to make sure that that group was delivering evidence-based stroke interventions, and that the practice time, that amount of practice, that intensity of practice was increased. So we were really clear around looking at the amount of practice, so the number of minutes that people were practicing for, and that intensity of practice, looking at the repetitions, so the number of active minutes and the number of repetitions. But we also actually audited what interventions were delivered, and that's included in the publication. Initially, there were a lot of non-stroke guideline recommendations being delivered, a lot of passive, non-active interventions, and that actually changed significantly as well over that period of time. You might want to select a methodology or approach to use, which I'm going to show you shortly. I think using a model can really help guide the process and remind us that we do need to measure before and after, and actually, again, often doing the cycle repeatedly helps us to make sure things are sustained and changed. We want to actually determine who else should be involved. So maybe you want to run an OT group, but you might need to actually talk to physios and speech pathologists, or depending on your setting, some other people or the nursing, to actually make sure that it's going to feasibly work. If you're in a mixed outpatient setting, then you might also want to make sure that it works with other groups or timetables or other clear barriers that you might already be aware of in terms of a person's therapy day. Confirm how you're going to collect your data and what you're going to do at each of the time points, and how you're going to evaluate it when you're going to modify what you're doing across the time point as well. So this is the knowledge to action framework. Again, it's very available online. I've got a reference there for you. But essentially, it identifies that there's all this knowledge that's available. You can do a knowledge inquiry. So maybe you want to find out a little bit more about how you want to run your upper limb groups for stroke participants. You might want to look a little bit more at the knowledge around how there is evidence around delivering certain interventions that we know we need to do high number of repetitions. And then you think about your own local service to identify the problem, or what's the knowledge gap? What do we know, but what aren't we doing? And identify and select what that would look like in the context of achieving that recommendation. And really identify what those barriers are and those facilitators to knowledge use. And then you select, tailor and implement those interventions. And then you check to see if it's working, where you hold essentially implementation meetings. You design something that maybe is going to override the problem, and then you evaluate it again, and then you keep going around in this circle. So I think it's really important to utilize one of these models to ensure that that the effects and changes that we're setting are sustainable over time. Another option, if maybe you're not so keen on using the other model, the good old plan, do, act cycle is great, because again, you plan, you identify your problems, you test out potential solutions, you then check to see if things have changed, and then you implement solutions again, and then you keep going around. Again, it highlights this continual process around implementing change and evaluating change over time. You really need to think about your local barriers. So maybe you already have a group running and you want to improve it, or maybe you don't have a group running at all and you want to set one up. So you really need to think about the environmental context. If you were going to run a group, where would it be running? Or if you are running a group already, is that actually the right place for it? Are there things that need to change? Do you have the right people in the environment in terms of the right participants, or the right therapists, or even students or allied health assistants, someone to help run the group? Are there things that can be changed? Are there competing tasks and time constraints? Are the necessary resources actually available? Is it just not just physical resources, but resources in terms of therapist capabilities and skills as well? Social influences, is it organisationally expected for people to deliver a high amount of practice in your groups? Is supervision delivered in terms of providing support to enable people to deliver the best evidence practice in their group programs? Is there feedback? Is there any conflict? Are things being discussed? So these are just a couple of elements from the TDF framework. These are just some examples, because I definitely think these are often issues when maybe you're setting up a group that you haven't run before, that we need to actually make sure things are all working together. And then also we need to look at some of the other aspects as well. But you will understand these local barriers, and you need to work through this together as a group. And you might identify all of the barriers and then keep going, but then you might realise that maybe there was one that you forgot. So on that continual process of evaluation and change, this is where you can find other opportunities for improvement, which is really important. So those implementation meetings are really key.
Emma, there's a couple of questions that you might want to talk about. The first one from Sarah is about whether you've got experience of running online groups for people. So I might let you answer that, and then I'll add in a little bit about Zheng Chao's session last year, because she did talk about that. Okay. Particularly with community, inpatient or outpatient services. Yeah, so to be honest, I don't think our organisation has done this very well, because I don't think it had been seen as a priority over the last few years, which I think was very frustrating and challenging. But given the COVID issues, I can appreciate the barriers. But I do think this is something that could be explored a bit further in terms of running online groups. We did try to run some telehealth-based online upper limb groups for our participants who were in a bed replacement model. So instead of being discharged to an inpatient rehabilitation group, they were discharged home, where nurses, doctors and allied health staff would visit them in their home daily, 5 or 6 days a week, to deliver their rehabilitation there. And during COVID, we tried to run an online group,
but we definitely ran into a lot of challenges. I think the population was probably an age group that wasn't really that used to using technology at that time, and it was rather problematic. But I also think staff weren't used to delivering rehabilitation online, and I think that has now shifted and changed, and I think it would be really important to identify some of those services that are doing it well. I've got a few more slides to go, but there is one there that's actually about delivering, say, MT programs online. One of our colleagues has delivered some of those resources.
Yeah.
I might finish the presentation actually, because I've only got a couple more slides to go, and then I'll come back to the questions if that's all right. So consider your overall plan of the group. What's the purpose? What's the goal? Why is this being utilised as a group? And what are the expectations of the group, not just of the staff, but also of the patients or any of the supporting staff who might be involved? Think about the environment, the equipment and resources. Are they actually available? Is it realistic? Is it going to work? If something is missing, then try and obtain it, or as best as possible. The level of participant ability, so their physical ability or their cognitive ability, how can people be included? Maybe the environment can only tolerate a certain number of wheelchairs, so then there might be a cap on the number of participants. The task focus, is it cohesive? Is everyone working on the same thing together, or is it disparate? Are they all working on individual tasks together? So maybe it could be cohesive in the sense that everyone's working on upper limb tasks, or it might be disparate in that some people are doing upper limb tasks and some people are working on, using a dressing aid, or they're working on their meal preparation or something like that. Staffing rotation, so thinking about how staff are going to be coming in or out of that position. Is there a position that's stable, that provides some coordination in terms of delivering that group? What's the skill level of staff? How do we make sure that we're supporting and training staff, particularly if they've never run a group before? How are we recording the records of the practice sessions? So we're making sure that we're monitoring the amount of practice minutes that are active and the number of repetitions, and that we're keeping good records. Have we got clear referral processes in line? And infection prevention. How many people are allowed to participate? Are people from different wards allowed to collaborate? How do we keep them coordinated in that sense? For a long time, we weren't allowed to bring and mix people from different wards. I think we're only just been able to do that recently. So we actually had to do a lot more disparate groups where people were coming together to do a lot of different things, because we could only run one group with everyone on that ward, instead of running a arm and hand group for everyone who had arm and hand goals to come together. So that's how we can think about cohesive or disparate groups, and how they might be having to be a bit flexible at the moment. So for an example, we used to run an inpatient group for inpatient rehab. We really wanted to increase the amount of rehabilitation time by using the semi-supervised group programs. We used to run it in shared space, but we were stopped doing that during COVID. So we actually ended up making it a roaming upper limb group, where a therapist and an allied health assistant would actually go around and set some people up in their rooms, or maybe someone had to go to a shared space, but maybe there were only one or two people in that room based on the limits of infection prevention at the time. And that actually worked really well. So it was definitely a semi-supervised group where people were set up to do practice, and we had a lot of requirements in terms of a patient had to be actually given their independent practice program already, and then that was used as part of their that was used in their group program. But the therapist running that group program had the autonomy to adapt and change that program if that was needed, and that could be fed back to the treating therapist. In our acute trauma unit, again, we wanted to establish an inpatient group. We really wanted to increase the amount of rehabilitation time through that semi-supervised group program. We weren't allowed to move people off the ward. We had to do it in the ward scenario. So we could only include people on that one ward. We had a really mixed patient cohort, and on average, people were really only in the hospital for 2 to 5 days. So we had to make it quick. And we actually did some audits of, who would actually be suitable to participate in a group. We had to kind of identify what criteria that might be. And initially we kind of got it wrong. And then we realized that if we changed it, we had to think about other aspects. We really looked at staffing ratios and staffing skill levels, and we actually identified and developed a skills for home group where people could either come in to do upper limb or upper limb exercises. They could do some dressing or adaptive practice. They could, or they could do like a functional mobility training and meal prep, because it was all in that same space. But we had to work really carefully with our other allied health professionals because it was a shared area and we had capacity limits in the room based on COVID requirements at the time. And that's just a table of contents from the manual or the group protocol that we wrote. It was actually done by a student. We had a student come in and actually led some of that work with our support, which was a wonderful resource. And this is the TeleCIMT website. So the TeleCIMT website is here on the screen, and there are a range of resources that can be used for remote or face-to-face or mixed models of CIMT delivery, which you might find helpful. And I'm just going to go now to the Q&A questions. I think Pauline.
There's one from Kate who's asking about whether there's any evidence suggesting how long after the stroke the aim for 100 minutes should persist for outpatients or people who are 4 years post-stroke, because in the community a lot of people will see individuals who are quite a long time post-stroke.
Yeah, thanks, Annie, and thanks, Kate, for your question. There is actually evidence regarding the opportunity for change after stroke. And while we know after a stroke, in that initial phase, there's a lot of physiological changes in the brain, and some of that tissue that may have been slightly damaged from the stroke but is still able to recover, can recover faster in those initial phases. It doesn't actually prevent people from being able to have neuroplasticity or neurological recovery after stroke at any point after that. So a lot of the studies that were included in my systematic review, in stroke research, it's often considered acute if it's less than 6 months after stroke, or it's longer if it's more than 6 months. So most of the trials are traditionally done on people who are less than 6 months after stroke, but there is very clear evidence across a range of trials that people should be offered rehabilitation at any point after their stroke. So even 10 years plus, people have been seen to have changes and improvements in their upper limb more than 10 years on. So there shouldn't be a restriction. I think it would be really person-centered in terms of if that's a priority for them, if they are willing to do the amount of practice that's required to guarantee change. And in terms of goal setting and so forth. But on the other hand, I have also worked with people that almost got addicted to the therapy in its way, but didn't really see a lot of change. So I think it's definitely a therapeutic decision, but in terms of the evidence for change, there's no limit on time since stroke.
And I might add too that in most of the national guidelines around the world and really evidence-based practice, the principle is if there isn't a study or a range of studies for acute or people who are in the community, you use the next best evidence, which is sometimes with an inpatient group rather than a community-based population. So the next question is about whether the group that you were involved in running at Alfred Health is still going.
Yeah, thanks, Pauline. Yes, it is now, but as I said, it was not running in 2020, 2021, or even most of 2022. So I 100% acknowledge that I think groups have suffered significantly. I know in my local setting over COVID, I think there are parts of Australia where groups continue to run, but definitely in Victoria and Melbourne, we were not allowed to run groups for a long time. And as I said before, I think it's we actually have to take a step back and recognise the impact that's had, not just on therapists and therapy staff, but even on organisational hospital environments. Like I remember the battle that we used to have to help nursing staff follow the timetable and actually have people ready for therapy. Well, I would imagine that we'd have to take the time to go through all of that again. And I think it's really key to consider using some of those models. So the knowledge to action framework or the goal plan, do review that knowledge, those models to make sure we're really implementing and monitoring over time how things change.
And then there's another question about how many people would you recommend in a group if there's one occupational therapist or physiotherapist to ensure the quality of what people are doing?
I think this is quite variable based on the participants that are attending and their care needs or level of support that are, or their impairments that they have. We have a kind of a ratio of 1 therapist to 4 patients. But if it was someone, maybe there's more people in a wheelchair, so maybe there's not people that need help to be, walking around, that might have an impact. If someone's very distractible or they aren't really able to participate on their own, you would then have to think if they could be brought into the group, how could we set up the environment to encourage them to be able to concentrate, or can they have a family member come with them to provide additional support? So I think it's definitely a variable question. I don't know if you've got anything else you want to say there, Annie?
Well, I think there's an assumption here, just so people know this, that people have already had an assessment and a prescription of their exercise program done by a therapist before they get to the group. You're not having to do any assessment there or set up a practice that hasn't been done previously. So ideally, you want to have a practice sheet that the person has that's saved in some central place, and you might have a trolley of equipment. So again, it depends, as Emma said, on how much help somebody needs to set things up often. And if there's a family member there, that often can, help reduce the amount of support somebody needs for setup. And I guess if somebody's doing a couple of different things during the hour of practice, they might need to change from one thing to another. They need a bit of help there. My experience in one of the hospitals was having an OT and a PT to help run the groups. And sometimes there could be 4 people in the group. Other times, if outpatients and inpatients were together, there could be up to 10 people in a group. So it could get really very busy. And that's when you did need to have people having family members there. And that was definitely encouraged. The next question is about how you manage pain if somebody's doing lots of repetitions. And that's an interesting question. We've had that often in the constraint therapy programs too. So you do have to anticipate the amount of work that somebody might be doing compared with how little they've probably done before. So how would you answer that, Emma?
I would actually answer it to say that it's quite rare for people to actually report pain when they're given a high repetition of the practice, if the practice is set up correctly. So I think we often feel like we shouldn't get people to do a lot of practice because they might have pain or they might get really tired. But the reality is that they need to do a lot of physical movement of specific activities and tasks in order to recover. So it's our job to actually set up their practice to enable high repetitions of practice that they can participate in order to achieve change. Even in one of the trials that I did, where we offered that extra practice session at the end of the day, no one got any injuries. There were mild reports of pain, but it actually never stopped anyone from doing their 60 minutes of practice a day. So I think we need to stop asking people if they're in pain because if someone asks me enough, I'll probably say, yes, I am, even though I might not be.
Yeah, and I think if we look at constraint therapy, where people are doing often 3 or 4 hours of practice, so this is quite a lot more than what Emma's describing here. I can only think of one person who had a problem with shoulder pain after the second or the third day of doing 3 or 4 hours of practice. And so what we did was we changed her practice on the following day to mainly focus on her hand and arm without any transport and lifting of her arm. So we kind of learned from that person. What's your criteria for people being in the group, Emma?
I think the criteria are varied based on the group. You might have been asking about the one for the acute ward, but essentially we needed to be able to. Well, the person needed to be able to be out of bed, essentially to sit out or sit in a position for at least the hour, and they needed to be able to. I think in terms of that time frame, they had to actually wear an N95 mask because we were bringing people together, but that is not a requirement anymore. They also needed to have already been assessed, and they had to have a goal with either improving their arm activity or their independence with being able to dress or use an adaptive aid, or being more safe or independent with completing a like functional mobility, like getting a hot drink or moving around a kitchen area. So the eligibility was directly related to the goals of the group. We did have, the main one really was around tolerance to being out of the bed. In the ABI unit where they ran the roaming upper limb group, that obviously could be adapted because we could actually set someone up to do their practice in their bed. So therefore they didn't have that criteria in that group.
Ruth's asking whether you involve nursing staff on the ward, particularly we had a group at the end of the day after therapists had left.
Yeah, thanks, Ruth. I think it wasn't one of the aspects of the practice that we were delivering. So it was definitely designed to be semi-supervised practice delivered by a therapist. So it wasn't designed to actually include nurses. However, the cultural change actually was incredibly positive. The space where the patients were actually doing their extra practice was right next to the ward like office, you know, the little booth where they come to get all the files. So there were a lot of nurses coming out. It was actually 6 days a week, so I was there on a Saturday, and it was very positive. People were really coming out. They were actually able to see their patients engaged in practice, and they might not have actually been able to see their patients maybe do some of the things with their arm that they were doing in the group. So I think they actually found it really motivating and really connected to the rehabilitation that the people were participating in. But no, they were not involved in providing support to deliver the groups on the ward. The Weekend Warriors is a group that was done up in New South Wales, and I know there's a paper that's been published which did actually involve nurses to deliver practice. And the group was actually led by one nurse who recognised that there was a need and felt really positive and actually led that within the nurse environment to deliver that group. So it was nurse-led, and it was actually an effective group at the time.
Thanks. Yeah, and that's been my experience too. Often the nursing staff are really interested and involved, and they may help people with their practice on the weekends and the evenings. So they often pick up some tips. Now Sally's asking, do you have the same group of people for the groups, or are there different people on each days?
Yeah, so they're different people, Sally. The groups are open, which means anyone can join at any time. And that's just because we are in an environment where patients are coming through their rehabilitation program. So either their acute bed or their rehab bed. So they're always open for new people to come in and people to go home. There are some examples of closed groups, but they're traditionally more around cognitive or communication groups, where it's really important that the content is delivered in certain times, and there's a real element of that group environment that's part of the actual therapeutic intervention. But for upper limb programs and the acute program that we were creating, we did not feel that it needed to be closed. So there are some aspects that you could consider if you're designing a group, but the groups that we ran, they were open.
Thanks. Siobhan's asking whether you use a particular resource to inform the group activities, such as GRASP or some other resource.
Yeah, we definitely use the stroke guidelines and the recommended interventions in there, and we were very focused on upper limb activity. So looking at the interventions recommended in upper limb activity. As Annie mentioned a little bit before, the people attending the groups had already been assessed by the occupational therapist, and an upper limb program had been designed for them. So they were coming with their designed independent, their personalised program. However, some resources that we had on hand that we could utilise to help set up an independent program were some of the GRASP kits, the GRASP programs. We had neuromuscular electrical stimulation machines, so people could be doing eStim if that was a part of their practice. We also would make task-specific practice worksheets, so set up practice sites or maybe a piece of cardboard with a clear exercise that someone would be doing, where they would have to come and bring that to do it as well. We also had some mental practice resources, so some resources to help the therapist to help guide someone participating in mental practice. We had mirror therapy resources as well, and just the other kind of stuff. But in terms of programs, yeah, the GRASS program, eSTEM, and some of the other interventions that I mentioned.
There's a question just come up, which is probably good to answer now. How many exercises or tasks would somebody practice within one session?
Yeah, I think that is a great question, isn't it, Annie? So the key concept of this is you need to deliver more of the same in order for that effective intensity of practice to have an effect. So 100 minutes of practice designed to target an activity or a task. So if someone's working on trying to reach for a cup to drink from the cup, there's elements of that practice that might build on those, those smaller components of practice. Part practice builds to the whole practice of that activity. So you could work on those aspects of drinking from a cup, but you really would probably only pick 2 or 3 at the most. I think if you're adding more than that, it dilutes the practice and it's probably really overwhelming. In fact, I might even, how I often structure my therapy is once I first meet someone and, we figure out how capable they are of practicing, I really want to teach them one thing to start with. And then my goal is to make sure that they can do that on their own or with a family member and that they can start doing their homework. Once they've learnt that, then I add something else in. And then once they've learned that, then I might add something else in, but that's probably the maximum. And then the other things get modified to build towards the overall activity goal. Don't know about you, Annie?
Yeah, I'd say 2 to 3 sessions in an hour because two to 3 tasks. So it might be external rotation and thumb abduction, or if somebody's working on a more advanced task like cutlery or writing, there might be 2 different aspects of practice to do with handwriting that they have to focus on. It might be the pen control and being able to turn the pen and pick the pen up repeatedly. And then maybe there might be some focus on writing and legibility. And 2 to 3 per hour is that's consistent with Catherine Lang's research group in the United States. So the studies that they did where they watched how much practice and how many repetitions people could do within an hour, they were getting people to do 3 different tasks during the hour. Now we've got time for a couple more questions. Is there any feedback from people, qualitative or incidental, about their experience of attending the group?
Yes, the feasibility group that I showed, that does have a qualitative aspect and it's all published. Overall, people were very happy with the group and they would recommend it to others.
Okay, and are your groups open groups, and how long did people attend on typically? What sort of time frame?
Yeah, most of the groups that we ran across the hospital are open, and they would attend for as long as they needed to address their goals. When that trial was done, it was pre-COVID, so people were in rehab hospitals as an inpatient for a couple of weeks to even longer than 4 weeks. But now people often go home. So I think we need to almost do this again in terms of how we can help set up those home-based group programs and maybe looking at telehealth or ways that we can kind of look at semi-supervised practice for people in the home environment where we're using those ward replacement models. Essentially the groups they're utilised as part of their rehabilitation delivery. So they've got a rehab program and part of their rehab is upper limb activity retraining. Then we utilise groups to increase the intensity of practice.
Right. I'm going to respond to Pauline's question, which is about long-term funding for people who want to access a group in the community. And it's a good point. Here in Australia with the NDIS program, people can, if they're under 65, can get funding for we're not allowed to call it rehabilitation, for maintenance to enable participation. And so quite a lot of private practices will run a group where people can come together and there's a different rate, hourly rate for a group rather than individual programs. And even outside of the NDIS, I've heard of an OT in New Zealand who did a similar thing. She could still cover her hourly costs if you had a few people together. 2 or 3 people doing the same activity. Do you want to comment on the funding long-term, Emma?
No, and I think No, I don't think I have anything else to add. There may be people who are seeking private rehab that may have more funding available to them, but yes, it can be a barrier, which I think is also highlighting the importance of delivering effective, efficient practice early when people have access to it.
Dion's asking how long people would typically be an inpatient before they can go and work in the community. And I'll just comment on that. It's quite variable. We talk about the postcode lottery, Dion, here in Australia, and I think it's not unusual. Depends where you live and what's happening at your local public health service. I think the average length of stay in Australia is about a month as an inpatient, but obviously there's a big variety. So, and once you're ready for discharge, you leave, and there may or may not be a community or an outpatient group available. Emma?
Yes, and it's changing quite quickly, I would say. There's a big push in Australia, particularly in Victoria, for a bed replacement model where therapy is delivered at home. There's obviously negative connotations with being in hospital. There's other risk factors associated with being hospitalised. So we're definitely trying to get people home earlier. And in actual fact, we have quite a high number of stroke patients who get discharged directly home from the acute service, and then they participate in that bed replacement in rehabilitation model where they're delivered essentially their inpatient rehab at home.
Yeah. 2 more questions and then we'll close off. People who've got very significant disabilities and impairments, how do you get them to participate?
Yeah, this is always a challenging question, isn't it? Because I always feel a lot of pressure to try and find something that someone can do in order to participate, because we know they need to be doing something to get better. There's, eSTIM's a great resource if someone doesn't yet have movement, but it's about finding something small. Maybe they need to be in a modified position to eliminate gravity. Annie and Carl are big promoters of scapular control. So scapular, this movement of moving your arm forward, that scapular protraction retraction can be a nice one to try and isolate in a gravity eliminated position. So with the arm supported on a table under rollers or a slide sheet to make sure there's not a lot of friction, and trying to pick one thing and keep trying is important. Try not to flail around so much that they don't have a chance to actually try and figure out what to do. I think there might have been another component of that question about people having difficulty participating. If it's a cognitive issue, then that can be challenging, but trying to use the environment to set them up in an area where there's reduced distractions. And it is possible that a person may need someone with them to practice. We know stroke affects cognition, attention and processing and all that kind of stuff as well. So it may be that they need a family member to be present, or they need an allied health assistant to appoint to participate for a period of time.
Yeah, no, you've answered the question. It's really about how do you enable people to participate if they have trouble remembering things or focusing. Yeah. Jess is asking if you have people comparing how they're progressing. If somebody's moving along very, very quickly and progressing well, and others maybe have no muscle activity.
Yes, absolutely. And I think that's a natural process of any kind of recovery. You always want to know how you're going compared to someone else. Whether that happens in a group or whether that happens just in passing, I think that's absolutely okay. I don't think it's ever been a negative connotation. I think people are very appreciative of that stroke can be quite different. I've certainly heard from people who maybe less physically disabled after stroke, who then see people with more severe physical disabilities end up being grateful, and actually I think it really does change their attitude to say, oh my gosh, I'm actually really lucky. But they probably wouldn't have said that if they hadn't have seen someone with a different level of disability. And I think people that maybe have a more severe disability see others and maybe seem hopeful. However, people have very different ways of interpreting that, and that's part of the therapeutic relationship. And as we know, there's often a need for someone to maybe be referred through to counselling if they are finding it really difficult. But again, it's part of their stroke recovery, and we don't need to shelter people and hide people from this information. I'm sure they're already thinking it.
Yeah, and I think that the discussion that goes on in the group, that's one of the whole advantages of a group is that people can encourage somebody who's earlier and having, more difficulty with their practice, saying, I remember what it was like. Last question from Tracy. Any useful resources about tele-rehab? You've already mentioned tele-CIMT, the website that I know Jess Boydell's involved in, and Lauren Christie has been involved, and they're evaluating currently doing tele-CIMT, so distance constraint therapy programs. We also had a recorded lecture that's on our StrokeEd website on telehealth, which Kate Scrivener and Lauren presented on last year. So what we know about doing tele-rehab, and they did talk about resources there. Anything else, Emma?
No, I think you've highlighted it, but I think a really important aspect of tele-rehab is really planning your session and being really structured in terms of how it's, what are the goals and how you're going to set it up, and how you're going to address clinical challenges on a computer. If someone's going to be there, how they're going to run it. So I think we've learned a lot over the last few years, and there's obviously still more to learn in this space. And I think it's hopefully something that we can continue to change and work with in the future.
Okay, thank you. I'll stop the recording now, and I'll just mention a little bit about the lectures coming up.